So good morning, everyone. Thank you, Praveen, for having me here. And I'll be talking, I'm Dr. Nikhil Gandhi, and my topic is going to be on neurobiometry. I do not have any financial interest. My practice is basically based in a town called Akluj, which is 160 kilometers from Pune. And I practice with my father, who is a general ophthalmologist, and my younger brother, who is a vitreoretinal surgeon. I'm into practice for my past almost 1 decade. So Praveen has given me this topic, and my patient has complained that I can see clearly with glasses, but you ensured me of spectacle-free vision. So why did my patient complain something like this? So to put in other words, you promised me, patient says, you promised me moon, but I got to see this. So where did we go wrong? So what has changed over a period of years? Like the patient's level of expectations have been increased. We need to match those expectations, and also to save ourselves from the medical legal issues. Because whenever you place a multifocal or a premium IOL and you promise too much, the and if the patient has got some issues, some complaints like this, we might land up into medical legal issues. So why did my patient complain something like this? Was it because of the proper patient selection? Was there insufficient counseling of the patient, or due to over promising during the counseling? Was there any glitch in the biometric IL power calculation, which is most common? Was there any intraoperative surgical complication that has occurred and we failed to manage it properly, or there was a post-operative management glitch that we missed in the pre-operative period, just like Praveen has mentioned? So which cases do we land up into surprises? The most commonest is the post-refractive surgery patients, wherein uh, we fail to take the previous history, and we are quite busy into our practice, and we leave it to our the optometrist to take the history and do the scanning, and tend to miss the post-refractive surgery patients, and wherein requires a special care in evaluating the IL power calculation. And also in the extreme axial length patients, like too short or too long axial length patients. Coming to the topic biometry, there are two types. One is the contact, and another one is non-contact. So in contact is applanation and immersion, whereas in non-contact is the optical or light. So applanation A scan gives a false short axial length due to variable corneal compressions, and the it might lead to corneal micro abrasions, and it is highly operator dependent source. So there are quite chances of getting a wrong IL power. Immersion A scan is easier alignment with the shell, so there is no corneal contact and improved consistency with less operator dependent, but it does not give much of a value other than A scan. Third is the partial coherence interferometry, which is a non-contact laser device which can be used in phakic, pseudophakic, phakic IOLs in posterior staphyloma patients with silicon oil, which is not limited by wavelength. So what is a perfect biometry machine? So the machine which would give you a correct axial length, a total keratometry reading. So total keratometry reading means getting a keratometric reading from the anterior surface and the posterior surface of the cornea, which I'll be talking on later, which would give us, or should be able to give derive angle kappa and angle alpha. This machine should also give the lens thickness, anterior chamber depth, white to white, and pupillometry. All these demands need to be satisfied by a single machine to achieve a satisfactory visual outcome and to make a surgeon's life easy. And these all the parameters need to be fit into the latest formulas to come to a proper IL power calculation. So the newer biometry machines do serve all the above needs. So I do not have any financial interest in any of these machines. So the latest one I'll be speaking is on the Zeiss IL Master 700. So if you compare with 500 as a IL Master 500, it is a 500 is a partial coherence interferometry, whereas Zeiss 700 is a source biometry, which takes into which does around 2000 scans per second at 0, 30, 60, 90, and 120 and 150 degrees angle, and which is quite fast. It gives all these parameters measurements in one go. And how do we compare with the ultrasound? Is the ultrasound A scan measures the axial length from the anterior surface of the cornea till the gross anterior surface of the retina, whereas the IL master or the soft source measures the from the tear film to the retinal pigment epithelium. Why is it really important? Because foveal thickness is about 150 microns from the which varies with plus or minus 20 from the age of 10 to 80 years, and the parafoveal area is between 0.10 millimeters to 0.16 millimeters thickness, which can manipulate or which would give you false. If you do an A scan, this would lead to a false IL power by the end of the measurement. This has got this, these latest biometry machines have got something called good fixation, wherein you can see a foveal pit in the image. And when there is when the patient is very well focused, if the patient is not focusing very well, as you can see in the right side, there's no foveal pit is visible, and this is a poor fixation. So by in the images, while doing the A scan itself, you can make out whether the patient was very well centered or not. Now, to give an example, in this patient, when we repeated the scan, as you can see in first and second scan, there is good fixation. You can see a very good foveal pit in both the slides, whereas the even the axial length is almost the same in the same eye when you repeat it. Only 10 microns of difference in the axial length. So this led to a hardly of 0.02 diopters of difference in the keratometry, and you get a regular, or you get a correct same IL power after calculations, after repetitions in this patient. But to come on to the second example, in the same patient, if the patient is not focusing very well, as you can see, you cannot make out any foveal pit, and this is called a poor fixation. And there is, as you can see, there is more than zero point 0.5 diopters of difference in the keratometry, and this leads to 90 microns difference in the axial length, and there is almost 1 diopter difference in the calculated IL power. So these machines can give you the can guide you whether the you are focused at very well at the center or not. Now, second thing, these machines they give they measure is the something called for keratometry is 3-zone telesynchronous, which gives 18 points and which takes measurements at 1.5, 2.5, and 3.5 millimeters and the center of the cornea. Total keratometry is something these machines they give is total keratometry is the new measurement combining telecentric keratometry and soft source OCT technology for the assessment of anterior and posterior corneal curvature, which have been used for the Barrett's formula. And this total keratometry, this improves the result of toric IL power calculation by 14% in your patients for plus or minus 0.5 diopters of cylinder. So the total keratometry is derived from it takes the measurements from the anterior surface of the cornea with the with the help of swift source OCT with the B scan. It takes the posterior 3D points of the posterior surface of the cornea, and combining these all, it derives to a total keratometry. So antichamber depth, it gives the antichamber depth evaluation for the effective lens position. It also gives the lens thickness and central cornea thickness. So with the, it gives value of white to white and pupillometry, which is important for angle alpha and angle kappa. Because if the angle kappa is more than 0.5 or zero point 0.6, we should not be placing, we should not go ahead with the multifocal IL, which might lead to glare and halos in the post-operative period. So combining all these measurements, we can apply it into these formulas and derive a proper IL power calculation. As you can see on the screen, multiple formulas have been used for different size and shape, lengths of the axial lengths of the eye. And as you can see, Holiday 2 text can be used for almost all the normal to extreme axial length patients. And this is something Holiday 2 takes into account with axial length, keratometry, antichamber depth, white to white, and the total keratometry. So with these latest biometries, you can use the latest formulas, wherein the Barrett's universal formula can be used for the normalized, and this Barrett formula takes into consideration of the posterior cornea into consideration derived from the nomogram, which Dr. Barrett had developed himself. So take home message is to for standard and expected post-operative outcome, you should be using the latest, you should incorporate the latest biometry into your practice. Proper counseling would save you from over-promising. Many manage any complications intraoperatively, and post-operative care is especially in special conditions is really required. So by using the modern equipments and the latest formula, would obtain a correct IL power, which would yield what you had promised for, and that would be what you had promised a moon, and the patient will be really happy in the post-operative period. Thank you.